Good afternoon, everyone. I, Vandita, on behalf of Hexagon Nutrition, welcome you for today's session. We are pleased and very pleased to have our second webinar in this series with ISPEN in collaboration with ISPEN. And I think it will be, all, of course, an educative session the way it has been always. And today, due to some reasons, dietitian Ashwini will not be able to join us. So in her place, Esther ma'am has agreed to moderate the session. And dietitian Edwina has graciously agreed last minute to be a panelist for this session. So we thank all the speakers and panelists today who will be giving this session to us. And I hand over the session to Esther ma'am.
Thank you, Vandita. Thank you, Hexagon, for this opportunity. I'm just sharing the slides and I'll introduce the speakers. Good to go, right, Vandita? Yes, okay. So welcome everyone. It's as part of ISPEN monthly webinar series. This month we are talking about nutrition in pancreatitis. We will deal with the entire spectrum of pancreatitis, right from mild acute to severe acute to chronic. We will keep the session interactive because we have a panel of experts, so all the views will be taken in. So before we deep dive, let me just introduce our speakers. Okay, so the first person to introduce is Dr. Ganshyam. He's not an unfamiliar person to us at all. So Dr. Ganshyam is a Director of Critical Care Medicine at Medicover Hospitals, Hyderabad. He is the General Secretary-elect for 2025-2026. He's also been Vice President of ISCCM, and he is currently the EC member of ISPEN, and he was the Organizing Secretary for PENSA 2022. And every year from 2016 or 17, he is the founding organizing secretary for HICS, which happens in Hyderabad. He is also a teacher, a lecturer, someone from whom all of us get to learn. And thank you, Dr. Ganshyam, for accepting our invitation and being here. Moving on to Dr. Zubin. He is a senior consultant, luminal gastroenterology and GI motility at Fortis Memorial Research Institute, Gurugram. He has been involved in a lot of academic events and also performed more than 3,000 manometric studies. He is one of the pioneers and has extensive experience in GI motility, and a lot of research has gone into it. He has done multiple workshops and training across India. He is predominantly a medical gastroenterology with specialization in GI motility diseases. Thank you, Dr. Zubin, for accepting our invitation and being part of today's webinar. Moving on to Dr. Monish. Dr. Monish is the consultant surgical gastroenterology and HPB surgery at AIG Hospitals, Hyderabad. He is a fellowship. He has finished his DNB in general and surgical gastro, and also a fellowship in hepatobiliary surgery and liver transplantation. He is again involved in a lot of research and training programs and has published a lot of papers in pancreatitis and surgical procedures around it. So thank you, Dr. Monish, as well for accepting this invitation. So moving on to Edwina, who stepped in at the last minute because Ashwini wasn't around. Thank you so much, Edwina, for doing this. Edwina is a PhD scholar and she's also a registered dietitian. She has more than 17 years of clinical experience in many private hospitals. She has won a lot of awards and recognition, is very proactive in clinical nutrition, does a lot of reading and studying and teaching. So Edwina will give us insights in terms of nutrition in pancreatitis alongside the three faculty members. So let's move on to the webinar and requesting all our panelists to unmute themselves because we will move on to, discussing and taking inputs from all of you. So just an introduction to what pancreatitis is. As the name suggests, it's an inflammation of the pancreas. And common causes are gallstones, alcohol, hypertriglyceridemia, especially when levels are above 1,000. It has been associated with acute pancreatitis. Diagnosis is serum amylase lipase. Imaging like CT and MRI confirm it. Classification of acute pancreatitis happens with revised Atlanta criteria as mild, moderate, and severe. At this point, I would want Dr. Monish and Dr. Zubin to just give us a little more on classification and stratification of pancreatitis, so that the audience can understand better.
Thank you, Dr. Esther. So, acute pancreatitis actually has a very wide disease spectrum, ranging from minimally symptomatic disease to life-threatening condition. As you can see in the picture, there are basically two phases: the early phase, which lasts for 1 week, and after that, the late phase, which starts after the 1 week. As far as the severity is concerned, we take two things into account. One, how the pancreas looks like on a CT, what are the local complications, and what are the associated organ failures. Based on this 2-point concept, we can divide the severity into mild, moderate, and severe. In mild acute pancreatitis, there is no organ failure. Whereas in moderate acute pancreatitis, there is organ failure, but it resolves within 48 hours. Or it may have local complications such as peripancreatic collections, vascular complications, or necrotic complications. Then comes the most feared one, that is severe acute pancreatitis, wherein the organ failure lasts for longer than 48 hours. Again, from an anatomical or a pathophysiological perspective, acute pancreatitis can be divided into two types: acute interstitial or acute edematous pancreatitis, wherein there is no necrosis, and acute necrotizing pancreatitis, wherein the necrosis plays a very predominant role in deciding the course of disease. Now, again, the prognostication of pancreatitis, we have a great role of CT scan, wherein we the next slide,
one. Okay.
Next one. So, for example, it looks at two things: how the pancreas looks like, and what is the percentage of necrosis. The pancreas can present with enlargement or peripancreatic inflammatory changes, or with one or more fluid collection. Then the necrosis, there could be less than 30. I mean, it is again categorized into three types: less than 30% necrosis, 30 to 50% necrosis, and more than 50% necrosis. Based on these criteria, every patient gets a score. The maximum score is up to 10. And as the score increases, we have higher severe disease. So that's pancreatitis in a very nutshell.
Thank you, Dr. Monish. Okay, so this webinar is in segments. Okay, so we have a segment of mild acute pancreatitis, and we end with a segment of chronic pancreatitis. So we start with mild acute pancreatitis. This is about 80% of pancreatitis that we see commonly is mild acute. But if you go back to literature, say around 30 or 40 years ago literature, there was a lot of NPO status, that is, don't feed any pancreatitis cases. But now there is a huge shift. There's a paradigm shift between moving from NPO to oral. So at this time, I need inputs from Dr. Zubin as why is there no need for an NPO status for mild to moderate acute pancreatitis? In what scenario, as a medical gastroenterologist, would you think that patients should be kept on NPO status and should be progressed slowly in mild acute pancreatitis? And do you find it practical in an Indian setting?
Yeah, I think it's a very, very relevant question that what you have put up. So before I actually answer, I just want to, from a nutrition point of view, acute pancreatitis is a dynamic disease. So what you are seeing in when we say first week is inflammatory and second week and onward is more severe and infectious complications, what we're trying to say that from a nutrition point of view, things will change. What you are feeding today, you will probably not feed the same after a week or so, or after 5 days or around 2 weeks. So as a nutritionist, keep anything in mind that things will change in acute pancreatitis as the time goes on. Now, coming on to the mild pancreatitis, when we talk of NPO versus actually early diet, I think it's very, very clear that we, now it is, start feeding them as soon as they can start to feed themselves. There is definitely no role of NPO as a treatment modality. Earlier, there was a point that, okay, you keep the patients NPO so that they don't kind of give out more of pancreatic juices, so the pain will actually come down. That is no longer the concept. So if it's mild, give them some feed to start with. In fact, there is clear-cut data which is now available that says that it makes no difference if you are giving a very early or immediate feeding versus the early oral feeding, and in fact, you may actually decrease the chances of further inflammation and decrease the morbidity and mortality. Particularly when we talk of mild, because if you keep them NPO for too long, you will have more complications possible because they are not having enough nutrition than the disease actually.
Right. Thank you.
Uh,
Yes, Dr.
I
Monish, you want to add
had a
on?
very
Yes.
small point over here. Yeah, keeping the, by not keeping the patient NPO, we're actually preserving the patient's gut mucosal barrier.
Exactly.
So very logical that the patients who are fed early on and who keep on taking something will have lesser infectious complication. This probably translates into lesser organ failures, lesser mortality, and lesser length of hospitalization. So yeah, it's
Right.
no longer NPO.
Yes. Okay, so to Edwina, so what is generally given in mild acute pancreatitis is we progress with immediate oral soft diet. Soft diets that are fat restricted post discharge, is it needed? If yes, how long do you recommend it?
Okay. Thank you, Esther. Thank you for that brief introduction, as well as organizing this such a great session. Basically, it's a good mutual learning that we all expect from this. Okay, somebody is asking questions. So to begin with, what we generally anticipate in these patients whenever they are admitted, they are in pain, basically their appetite is poor, and that is where we start slow. But early feeding is something that earlier also it was emphasized. It is rightly mentioned that gut integrity is something that we can preserve by starting as early as possible. So depending on tolerance, depending on how much the patient could accept, depending on pain and their appetite, we would start with soft diet, and then low fat is something that we begin with. So for about initially about 15 to 20 grams, then progress to 35 grams. That is about less than 25 to 30% of total calories of fat that we fix initially. So mostly hospital diets, hospital feeds are low in fat, as we all know that. So we begin with this in early feeding stage, and then the next stage is transition phase, where we start adding additional fats into patient's diet depending on tolerance. Again, post discharge, we would consider the patient to progress to a balanced diet. Probably a moderate amount of fat is provided here, rather than restricting fat completely or going on extremely low fat is something that's not advisable.
Thank you. Okay, so the summary, just to summarize the segment 1 on mild acute pancreatitis for the entire audience here. First point is that we start feeding immediate, depending on pain tolerance and what the medical gastroenterologist has advised. Second is we give a soft diet, which is predominantly by itself a low fat. So we need to understand we don't give boiled food kind of a diet. We give low fat. It is not fat-free kind of a diet. Because Dr. Monish and I were having a conversation this morning, and he was like, why can't my pancreatitis patients have a gulab jamun in the post Whipples? So if gulab jamun comes under a soft diet, there is no harm including the gulab jamun. But we transition slowly the way Edwina had explained. We start off slow with minimal amount of fats and then slowly advance it. So this is a summary for segment 1.
I mean, just
Yes.
one small
Yes,
point.
yes.
Yeah. So what I insist is, let's not go too literal on low fat.
Low fat, yes.
Low fat may be synonymous with a soft diet, and I'm
Soft
okay
diet.
with it. However, evidence does not say low fat versus normal fat diet. The studies haven't explored this part yet.
Yes.
So
So
let me
AISPEN
just
guidelines. Yes, Dr. Zubin, go on.
let me just quickly comment on this data part. So the issue is, when you actually tell a patient for low fat diet, now it translates to almost everything going out in their diet.
Yes.
There's a very good meta-analysis, and I think clinical nutrition by a Japanese group, I think Yang et al, something like that, and they actually compared a full diet to a low-fat diet to a clear liquid diet. So the
Right.
full day diet actually had lesser pain rather as compared to a low-fat. So all the recommendations are there. Even in our ACG guidelines, they say you do a low-fat diet, but the quality of evidence that is available to make that recommendation is
Mm.
actually not very great. So it's not a sacrosanct that we really have to push aloof at that.
Right. Yes. Okay, so that's a point that I think dietitian colleagues should note, that we don't keep them on a very boiled food kind of a diet. And so even if it is low fat, it's up to 25% of calories, which is equivalent to what you and I normally eat.
Right.
So, it is important point at this for this segment is that we don't keep them NPO and we start the feeds soon. So moving on to segment 2, which is more serious, severe acute pancreatitis. Here again, research moved, huge, because there was a time when all severe acute pancreatitis getting admitted in the ICU were kept NPO. Then it was a time where everybody was started on parenteral nutrition. Then there was a time when everybody was started on nasojejunal feeds with semi-elemental formulas. And now it is more of polymeric formulas. It is more of nasogastric versus nasojejunal. So I need experts here, because this is a phase of pancreatitis which is having more complications. And I think as dietitians, we need to understand when, what, and how to be used. So starting off with Dr. Gansham, because severe acute pancreatitis patients are in the ICU. So Dr. Gansham, how early is too early? So in mild acute, we said, okay, within the first 24 to 48 hours. But in an ICU for severe acute, how early is too early? And when do you actually delay enteral feeds for these patients?
Thank you, Dr. Esther, for the kind introduction. It's not just something which is pertaining to severe acute pancreatitis, but in general, even for other critically ill patients who are admitted to the intensive care unit, I think the entire the focus is being shifted for early enteral nutrition. Again, just to kind of reiterate or highlight the point, we are not looking at delivering the complete calories or proteins when we're talking about early enteral nutrition, right? The idea is to give small amounts of luminal feeds, because even small amount of delivery of nutrients into the gut lumen has shown to have benefits in terms of preserving your uh, gut integrity and preventing the bacterial translocation. However, like the general guidelines say between 24 to 72 hours for almost majority of the critical ill patients, including severe acute pancreatitis. But the only thing you need to be very, very careful is when we're talking about severe acute pancreatitis, a good number of these patients may be in inflammatory shock. So the priority for any critical ill patient, irrespective of the diagnosis, is the initial resuscitation, right? Now, if your resuscitation is not complete, or if you have a shock which is worsening, or if your vasopressor doses are, you need to keep on escalating your doses, then just hold on. Anytime, if I feel my gut is not ready, then that is early for me, right? Make sure that your resuscitation is complete. You achieve stable hemodynamics. That does not mean that they're completely off vasopressors, but you should not be in a situation where your vasopressors are continuously being escalated, your acidosis is worsening, your lactates are increasing, you are very much in doubt of whether your gut perfusion is being maintained or not. In such situations, you should be careful. Okay. So there is no fixed time frame, but if I have a clinical situation where I feel my gut is not ready, that will be too early for me. Okay. Do mechanically ventilated patients on inotrope support need more time? No, not necessary. There is good amount of data. All the Nutria trials have very, very clearly shown that you can start your feeds even if the patients are on vasopressors. However, as I've said, right, the dose of vasopressors has to be reasonable. A norepinephrine dose of 0.1 to 0.2 microgram per kg per minute is fine. Or if I'm able to maintain a stable mean arterial pressures, I'm okay with that. But only in situations where my vasopressors are continuously escalating, my lactates are going up, or my acidosis is worsening, my organ functions are failing, then I would be a little careful. As I said, our focus is not on delivering the entire amount of calories or proteins. In the initial stages, we are looking at small amounts of feeds. It could be even as less as 10 to 20 ml per hour. Even those volumes of feeds have shown to have significant non-nutritional benefits.
Right. So, from your experience, Dr. Ganshyam, this question is not in the slide, but then I'm asking you, from your experience of handling pancreatitis cases, how long does it take for you to achieve hemodynamic stability for these kind of severe acute on a best case scenario?
It varies from patient to patient, but any resuscitation, I mean, in fact, if you look at the, I mean, the way the resuscitation in intensive care is moving on, right? There was a time where we would give continuously, we would pump fluids. I mean, during our internship days or early part of my critical care, we were taught that if it's pancreatitis, just keep giving fluids. But that concept is changing. That concept is changing not only for pancreatitis, but for a large subset of patients who are in the intensive care unit. We are no longer, pumping in fluids days together. Most of the times, we aim at completing the resuscitation within the first 24 hours, right? We hope that it happens. In some patients, it may not be possible. In fact, resuscitation is a dynamic process. It keeps fluctuating. If the patient is having a severe inflammatory shock with severe capillary leak, and then it is a nightmare for us, because you give fluids, blood pressure will stabilize, then again it will leak, then again you give fluids. So if you're lucky enough, 48 hours, you should be able to get reasonable pressures with not very high vasopressors. But if the severity is very high, if you're unlucky, then it keeps on going. In fact, if you look at the cause of death for majority of these acute pancreatitis in the initial stages, is the inflammatory shock which kills them.
Right. Okay, so suppose you have patients, like you had mentioned that you will be giving them luminal amount of trophic feeds, basically.
Yes.
Would you consider supplemental PN?
Not early. Not so early. Though let me just clarify this. One of the major fears of parenteral nutrition in the initial stages was should we give it in a patient, or how safe is it in a patient who is in the initial stages or in shock. Again, the Nutriria trials have shown that it is feasible and it's safe to give parenteral nutrition or enteral nutrition when the patient is in shock. I think the major concerns or the major worries are with the dose of nutrition that you give. There is a clear no with full dose feeding, right? That is very, very clearly shown that if you give full dose feeding in the initial stages, the outcomes are bad. But supplemental for PN for me, very early, I would hold on. Okay.
Right.
Get the registration complete. I'll try to make every effort at making the gut work, right? And if that is not working, then yes.
Okay. Thank you, Dr. Ganshyam. Moving back to Dr. Zubin. So if you have a patient with hypertriglyceridemia-induced pancreatitis, what is your rationale for giving fat-based emulsions and dietary fat? Could you elaborate on that, both enteral and parenteral?
Yeah. So again, as Dr. Ganshyam said, in any case, whether it's the hypertriglyceridemia or a biliary pancreatitis, the first priority is to start the gut functioning. You have to have enteral nutrition in place of parenteral nutrition, even for a triglyceride-induced pancreatitis. Now, the challenge with triglyceride is, so we have to understand, it's not only the diet that is introducing triglycerides, it is usually the intrinsic synthesis of those triglycerides that is causing the problem in these set of patients, because they have some genetic mutations which is causing a kind of a different metabolism, which we have triglycerides going beyond 1,000 level in the blood. So the first priority is to bring that down to less than 500. Once you have brought that down by various means, you can start insulin, you can start heparinization, or all those or even statins for that matter for method. Once you are below 500, you can actually give a normal low-fat diet which you give for any pancreatitis. You don't need to really specially constrict fats even in these set of patients. Even if you're not able to bring that down to 500, you can, in case you really want to start your diet, you can start an MCT-based formulas or a monomeric formulas if you really want to start them on enteral nutrition. So triglycerides for me practically management point of view, they do not change too much of dietary formulations in my patients. Yes, but my target to bring the triglycerides down, that is more aggressive in various medical means, whether insulin, hyperinflation, or something. So that's the main concern regarding the triglyceridemia-induced pancreatitis.
Thank you. Okay, so we finished a segment of TPN and NPO versus TPN and supplemental PN. Let's move on to the next pressing thing about severe acute pancreatitis, jejunal feeding versus gastric feeding. So earlier, everybody was put on jejunal feeds because they wanted to bypass the stomach. But current literature says that, nasogastric feeds are safe. So in your practice, Dr. Zubin, Dr. Monish, Dr. Ganshyam, in your practice, do you feel that post-pyloric feeding is underutilized in India and Asia? And when is it that you look at post-pyloric feeding in your practice?
So see, post-pyloric feeding, I mean, where I worked in Medanta and I worked in Fortis now. In fact, it's a overused one. I'll not say underutilized. It in fact is an overused one. We like practically started putting NJs for every pancreatitis who is moderate or who is severe, which doesn't really make sense. I think it's not something we should be doing. The only place where I would really want a post-pyloric feeding is two indications: when there is some element of intra-abdominal hypertension where the pressures are high, patient is not able to tolerate gastric, NG diet. And usually I look at that in an anatomical point of view. If my scan is showing a lot of inflammation in the lesser sac, the stomach hole is kind of reduced in the volume, that's where it tells me that I would probably need to put in a post-pyloric tube in. Now the challenge with post-pyloric feeding is threefold. It's not only about putting the tube; it's actually difficult to put. You'll need at least a fluoroscopy, if not an endoscopy, to put that tube in, or even ultrasound in ICU. I think Dr. Ganshyam would probably know that. Second challenge would come care of that NG tube. And thirdly, let me tell you the amount of feeding you can actually, it's a narrower lumen. The NJ is a much narrower lumen than an NG. So even the feeding is, they get locks very easily and all that stuff is there. So in my opinion, in mild, moderate cases, even severe cases who can tolerate NG is good. No need for NJ, no need to shift the patient anywhere. Yes, inflamed lesser sac, put intra-abdominal hypertension, put in an NJ.
I completely
Dr.
agree.
Ganshyam, Dr. Monish, do you want to add on?
Completely agree
Yes.
with Dr. Zubin. The only indication is a patient who has got gastric outlet obstruction due to significant inflammation in the lesser sac. And if we're underutilizing post-pyloric feeding, that means we're turning smarter. So it is to be done that way. Yeah.
Right.
I agree the complete the logic and the rationale and explanation. I think why we are using more of NG is very simple. It's very simple to to insert an NG tube. Anybody in the night, whenever the patient comes, can insert an NG tube. You don't need expertise at the end of the night, in the middle of the night when the patient comes to you. So once an NG tube is placed, and since the evidence has very clearly shown that NJ does not offer any major significant benefits. Once your NG is there and you start feeding, and if the patient tolerates, many a times you don't need to actually shift over to NJ. So it's not that people, and we are not utilizing NJ. As both Dr. Manish and Dr. Zubin have said, I don't think there is, the majority of the patients don't fit into the subset of patients where you need NJ.
Right.
NG is much more simpler, cost effective, technically does not need a major expertise. You don't need advanced equipment. Anybody can put it. So that's the reason why probably we were not using NJ much.
Okay. Thank you. So moving on to the next third part of this segment, polymeric versus semi-elemental. I think semi-elemental formulas, everybody started using it because at that time, nasojejunal feeds were given. And in nasojejunal, we thought that, okay, digestion will be a challenge. So let's start with semi-elemental. And also because it is pancreatitis, protein digestion and fat digestion is questionable. So went on to semi-elemental formulas. But here at this point, I want Edwina to add on. What does evidence show? And does it differ in our clinical practice?
Yes. So as dietitian, I would always prefer NG NG feed, which is more convenient. Even to always my first choice would be standard polymeric formula, although it is more cost effective, as well as I'll be able to meet the calorie, protein, fat requirement through standard polymeric formula. Of course, if it is well tolerated, in case of the intra-abdominal pressure goes high and the patient is forced to be provided with NJ feed, that is when we will have to resort to semi-elemental feed. Of course, to meet the requirement of protein is always a challenge. So we should, when it comes to semi-elemental formula, I'm sure even you agree with that. So we will have to take it slow at times. When the pressure is high, we will have to give slow infusion. So I would say, of course, the benefit of MCT and would be there when it comes to semi-elemental formula if we choose that. But standard polymeric formula is still being tolerated to meet the actual therapeutic goals, I would say.
Yes, thank you. So just to summarize what Edwina said, a good paper where they found that, early enteral feeding with polymeric formulas did not, comparison between elemental and polymeric formulas, it did not have significant difference in LOS, sepsis, and hospital-free days. So using polymeric formulas is safe. There is a lot of recent literature leading on to ASPEN and critical care medicine guidelines, where they say that polymeric feeds have to be preferred compared to semi-elemental, and semi-elemental is not routinely needed. So, so this is a summary of severe acute pancreatitis. This flowchart is taken from ASPEN guidelines 2024. Very clearly showing how we manage severe disease of acute pancreatitis. When is EN started? When do we use supplemental PN? And if there is intolerance, what do we do? So this paper is free to download. All of you can just download it and try to understand.
Sorry
So
to interrupt. I think it's been
yes.
highlighted even there that unnecessarily we need not have to give any probiotic-based formulas.
Yes. You want to add on a little more on that, probiotics and
I just
enzymes?
wanted to highlight that even the recommendation, most of the formulas are coming up with the probiotics added. So this we will have to be little careful about.
Yes. And also, we will go a little more deeper, taking inputs from all the doctors as well about pancreatic enzyme supplementation. But in this segment, both Dr. Zubin and Monish, and also in the end, Edwina had mentioned about intra-abdominal pressure, hypertension. And that is something that we're going to talk about in segment 3 for the dietitians to understand, because this is something that many dietitians in routine practice might not be looking at it. And would need inputs from the doctors to understand how does intra-abdominal pressure impact the nutrition intake, and how do we transition the feeds in such a case. So Dr. Zubin and Dr. Monish, can you highlight about IAH and the abdomen compartment syndrome?
You need to understand that acute pancreatitis is a quite an inflammatory situation, wherein we have increased capillary permeability and vasodilation. This actually moves the fluid from the intravascular compartment into the interstitial compartment. The fluid resuscitation that Dr. Ghanshyam talked about just a while ago, this also adds to the increased interstitial pressure. Now, all of this leads to bowel wall edema. There is a paralytic ileus. Now, these 2 or 3 factors combined to raise the overall pressure inside the abdomen, which manifests as intra-abdominal hypertension. We call it intra-abdominal hypertension when the intra-abdominal pressure is more than 12 millimeters of mercury, and we call it abdominal compartment syndrome when the pressure increases to more than 20 millimeters of mercury. Now, what is the organ system that is first checked? They're the kidneys, because the increased intra-abdominal pressure compresses the renal vasculature, decreasing the blood supply, leading to oliguria, anuria, and finally to acute renal failure. Next up, there is splinting of diaphragm, there is decreased compliance on the lungs, and there is ventilatory perfusion mismatch. And the gut, because of the increased intra-abdominal pressure, the perfusion pressure of the gut comes down significantly. There is decreased blood supply into the stomach and the small intestine. which leads to a situation like mesenteric ischemia. This again aggravates the paralytic ileus. So there's a vicious cycle wherein the pressure inside the abdomen keeps on increasing.
Right.
Yeah.
Dr. Zubin, do you want to add on to this?
No, yeah. So what I want to just say, that's, even when you go to your ICUs, you see these patients who have intra-abdominal hypertension. Even if you're in a smaller ICU where the values are not really being monitored, just keep a hand on the tummy, and you will really know that this patient has a significant abdominal hypertension. Once you realize that, then you only know that actually cascades down. So these are the difficult patients for enteral nutrition. If they're some of them will be really tight, the gut is not moving at all. It's almost like a paralytic ileus. So you have vomiting, you have high GRVs. There's a lot of like aspiration. So these set we can try for a post-caloric feeding. If that doesn't work out, some of them will require some period of parenteral nutrition where you have to use that till the time things are better off.
Right. But is IAP routinely checked for all pancreatitis cases?
No, not all. I
Not.
mean, in good ICUs, in severe pancreatitis patients, they do check. But I will say that it is still not very routinely checked for almost all. And it's not even recommended, honestly. I think only in patients where there's a prolonged stay, abdomen is very, very tight. I really have to know, I need to know that objectively the values to, like decide. So most of my patients do not require it. Only rarely when something I have to take a call on my surgical interventions early in the disease, which is rare nowadays. That's where I probably end up using this value.
Okay. Yeah. So that was the question. Do you routinely monitor? Yes.
Just
Yes, Dr. Gansham.
The concept of intra-abdominal hypertension, or at least I was introduced to the concept way back in 2004, 2005, when my boss, under whom I was getting trained, Dr. Jose Chaco, for the first time, he measured the intra-abdominal pressures through the Foley's catheter. So it was very, very, very exciting thing for us to, to see a different use of a Foley's catheter. Do we commonly monitor? I totally agree with Dr. Zubin. Probably we are not monitoring it as frequently as we need to. So the problem is most of us, we wait till a point where we think that clinically, the patient is having abdominal compartment syndrome, and only that's when we think of monitoring the intra-abdominal pressures. But I think sometimes that can be misleading, right? For a long time, people used to rely on measuring the abdominal girth, which is completely unreliable. I mean, I used to see many ICUs or the patients used to have a tape, with a routine measurement of the abdominal girth, and based on that, having an idea about what's happening to the intra-abdominal pressure. But that is completely unreliable. If you are doing it, please give away with that practice, because that doesn't actually tell you what's happening at the perfusion of the kidneys or the gut perfusion. Should we do it more commonly? I think yes, that is something that we need to do it, because see, by the time we clinically realize that the patient is having abdominal compartment syndrome, it could be a little late. By then, your intra-abdominal pressures are more than 20, your organ dysfunction would have set in. But if you are monitoring it more frequently, then there is a chance that as soon as the intra-abdominal pressures go beyond 12 or 15, you would be more careful with your fluid resuscitation or de-resuscitation. You should be more careful by at least employing those techniques which are under your control. For example, use of prokinetics, or trying to make your gut move, maybe laxatives or enema, or change your resuscitation strategies. Many a time, as intensivists, we are looking at or we think about it when we see an unexplained renal deterioration or unexplained deterioration in your pulmonary functions. But I think when that organ function is already set in, maybe it's a little kind of a little late. I personally feel we probably should be doing it a little earlier, before at least in any condition where you need massive fluid resuscitation, like not just pancreatitis, but also patients with burns or patients with severe trauma, where we give lots of fluids. Even these are the patients where there could be intra-abdominal hypertension and abdominal compartment syndrome setting in. As I said, will it alter my feeding decisions? Yes, definitely, because as your abdominal pressures keep going up, the chances that you will be able to achieve your complete nutritional targets through enteral feeding alone will be very, very difficult. You will have a very, very high incidence of enteral feeding intolerance. And probably this is the time, if you are not able to meet your nutritional goals, you should be looking at supplementing it with parental nutrition.
Right, right. Thank you. Thank you, Dr. Ganshyam. So, Dr. Monish, when do you do surgical decompression? Do you do it? How often is it done? And does it improve outcomes?
To be very honest, surgical decompression is always last resort.
Mm.
Nobody should jump onto the surgical decompression upfront. Initially, we try all these conservative measures like obviously, all of these patients will have a nasogastric tube. We need to decompress the stomach and the small bowel. Can put up a rectal tube to decompress the colon. Then go slow on fluids, moderate resuscitation. Can use diuretics, even dialysis. Then to increase the compliance of the abdominal wall, one can give better pain control, can use neuromuscular blockade. Once all of these things partially work or probably did not work, you go in for invasive interventions. Like you can try ultrasound guided paracentesis to drain out some ascites, or can even try to drain the necrotic collections. When even these maneuvers haven't worked, you finally decide for a surgical decompression. So what we do is we do a laparotomy, we decompress the abdominal compartment, and most of the cases we'll have to leave it open because closing it again will again perpetuate the intra-abdominal hypertension. We actually suture a plastic bag or a Bogotto bag to the edges of the wound. Then the abdomen gets decompressed. There could be improvement of parameters, the perfusion pressures. If the patient comes out, then he's pushed into the recovery trajectory. Now, however, one needs to understand that a patient who requires surgical decompression is a very sick patient and which carries a mortality of more than 50% even in the best of the best centers. So we are dealing with a very difficult situation.
Right, right. So I think Dr. Zubin, you would answer that point, where so we'll move on to Edwina. Edwina, can you just summarize the feeding strategies that is recommended by ISPEN?
Yeah. So when it comes to the IAP level, we've already, doctors have explained about this. So whenever the pressure is going up, that's when the tolerance becomes challenging. Probably when they're on NJ feeds, we got to start. And these patients, they really tolerate well if the infusion is slow, rather than giving them bolus feeds and so on. So slow infusion, a slow rate of infusion would be better with lesser volume. To begin with 20 ml per hour is something, then later we can progress further by increasing the volume. So that is well tolerated, whether you would want to choose semi-elemental or standard polymeric formula, it's up to you, depending on your hospital protocol, what you follow. And then probably when the pressure goes much higher and doctor tells you to halt EN, and then there is high risk of gut ischemia, there is intolerance with patients, gastric emptying is delayed. So that's when PN, when EN is contraindicated, then we will have to switch to parenteral nutrition. So, if not, I think with enteral nutrition, we have seen good results. Rarely in our setting, we have used parenteral nutrition.
Thank you. Thank you, Edwina. Okay, so moving to the fourth segment, we have about 7 minutes to wrap this up. This is mainly on severe acute pancreatitis, patients who need to undergo, with necrosis, who need to go undergo necrosectomy. So Dr. Monish, after necrosectomy, how quickly can we resume feeds? And do you prefer jejunal feeds in complex cases?
Yeah. So the ideal answer or the practical, or the good answer would be as soon as possible. May not always be practical as such. So ever since the endoscopic necrosectomy and percutaneous necrosectomy has is doing most of the necrosectomies, we get only the most complicated ones, the ones which have a bowel perforation, bowel obstruction, bleeding, etc. So once surgically these issues are taken care of, for example, in an obstruction or a perforation patient, we would do a stoma. We can resume the feeds as soon as possible and increase it as per the tolerance. Now, do I prefer a feeding jejunostomy? Yes. In complex cases, I would rather err on the side of performing a jejunostomy because I don't want to do a second laparotomy on a patient just for doing a feeding jejunostomy. My rule of thumb would be like any patient who is on NJ would have less tolerance to oral or other enteral feeds or an NG feed. So I'll do a surgical feeding jejunostomy, as tolerance is better with surgical feeding jejunostomy compared to an NJ.
Okay. Okay, so this is again the flow chart from the same paper that I had mentioned to everyone. So, you can download this and see. This is about management after a necrosectomy. Dr. Ganshyam, coming back to you in terms of prolonged ICU stays with persistent organ dysfunction, how do you, change or modulate the nutrition strategies? And how do you monitor nutritional deterioration when the patient is with you in the ICU?
See, assuming that this is severe acute pancreatitis and we are in the later stages,
Right,
right. You should kind of assume the fact that this patient is in a state of persistent inflammatory catabolic state. So his or her nutritional requirements would be significantly higher. And this is a time period. I wish I can have an indirect calorimetry, right? If you have indirect calorimetry, probably these are the times where you can be very, very appropriate with your nutritional targets. But if you do not have, which majority of us don't have, maybe the idea of continuing with trophic feed should be given away. You should be looking at full feeding, at least 25 to 30 kilocalories of your energy, at least a minimum of more than 1.3. You can go up depending upon the renal functions and the need for extracorporeal interventions. So one, you should be looking at every means of achieving your caloric and nutritional goals in this time period, right? There is no, you would have already lost a significant muscle loss. We are looking at least a week or two of already being into the intensive care unit with a severe inflammatory response. So you need to look at every strategy of getting your nutritional target right. It could be purely enteral, it could be purely parenteral, it could be a combination of both. Whichever is suitable to your patient needs, you need to look at that. And if your patient was not on complete enteral needs in the initial, or was not able to meet, then you should be also looking at supplementing your micronutrients. Now, there could be a lot of clinical, signs which can tell you that probably your nutrition has already lost. One, you might find that these patients are difficult to be weaned off the ventilator. Many a times you'll find that these patients are not coming off the ventilator, or these patients could have landed with severe critical illness polyneuropathy, or myopathy, which suggests that they would have lost significant lean body mass. Now, since this is a patient of acute pancreatitis, I would assume that he would be requiring a few CT scans, which might be indirectly helpful to us in assessing the paravertebral, muscle quantity. So that will also tell you how much muscle is lost. Biochemically, not very reliable, but then again, your anemia, your hypoalbuminemia, your severe electrolyte imbalance, all are subtle hints that this patient has depleted nutritionally significantly and needs to catch up on whatever he has lost.
Right. Okay. So we come to the last segment. We spend 5 minutes in this. So just to summarize to all the complete audience, we started off with mild acute pancreatitis, went a little more in depth with severe acute pancreatitis, and we have come to the last segment where we're talking about chronic pancreatitis. So chronic pancreatitis, there is a huge prevalence of sarcopenia, steatorrhea. There can be sugar spikes. There can be exocrine insufficiency and endocrine insufficiency. So nutrition management of chronic pancreatitis is very different compared to nutrition management of mild acute pancreatitis and acute severe pancreatitis. So coming back to Dr. Zubin, How do you diagnose and manage pancreatic exocrine insufficiency in chronic pancreatitis? Do we do fecal elastase testing? And is that a good thing to do to monitor? And how do we start modulating the diets for these set of patients?
So I think it's a very relevant patient group which will have pancreatic exocrine insufficiency in terms of chronic pancreatitis. So we are always looking for ways for where we can identify PEI as early as possible. Unfortunately, there's no good reliable test which gives it early enough. So the only really way is to go clinically when somebody starts losing weight or saying that they have diarrhea. We do have fecal elastase testing. It is available now in a lot of various centers. It's not something that is uncommon now. But then again, how do you change it? Even if you do a fecal elastase testing and it's coming very low, if it comes very low, patient would be clinically obvious. They would be having some amount of fatty, loose stools that are going to happen. In borderline cases, although even if you start them on some treatment in form of supplements with pancreatic enzymes, things may not change much. Eventually, they will go downstream in terms of loss of parenchyma and further worsening of pancreatic exocrine. So more important is that how do you manage once you have proven it? So go clinically, go by the symptoms, go by fecal elastase. Sometimes we do EUS. We can do a EUS is an endoscopic ultrasound to look for pancreatic elastography, which is probably the earliest way of identifying these set of patients. But the correlation between our imaging to actual functional loss is not very great right now.
Right.
Yeah,
Okay,
I
across the
recently
panel.
read
Yes, Dr. Monish.
Okay, I mean, a recent meta-analysis said it's not the best, but that's what we have. The fecal elastase for from the Spanish group. Yeah.
How do you manage the nutrition status for these patients?
So I think the most common problem that I see in them is ongoing weight loss. It will be both for fats, it will be for proteins, and they will be sarcopenic, most of them. I think, in fact, more than our role, it is a dietitian's role in these set of patients, which is very, very, very important. So we have to first prove that they do definitely have fat as well as protein malabsorption. And if pain is not really an issue, there are set of who pain will not be a problem. We directly jump on to adding a lot of pancreatic replacement or pancreatic enzyme replacement therapy or PERT in them. We do add, I personally do add antioxidants. I'll add some selenium in them. I'll add some manganese in them, magnesium. It also works to some extent in pain. But the amount of the dose required of those antioxidants is pretty high. So the routinely available drugs are not really good enough for them.
Right.
Diabetes is difficult to treat in them. That's something which we have to really manage well with our endocrinologist friends. They might be needing shorter acting insulin than the longer acting ones. And B12 deficiency is common in them, but it's more of folate right now. And if there's an ongoing alcoholism, ongoing drug addictions, which some of them have, particularly for opioids, that becomes a hard patient to treat. So I think that's where we need all your expertise to come again.
Yes.
Calcium deficiency, vitamin D deficiency is also widely prevalent. Maybe bone assessment through DEXA, or instead of checking only BMI, probably bioelectrical impedance with calf circumference, or maybe functional tests needs to be incorporated routinely at least once in 6 months or so. And insulin, glucose management is something that's needed through our diet advice.
Right. Dr. Zubin, because you mentioned about antioxidants and pain management, a lot of times when we as dietitians see patients with chronic pancreatitis, we see a prescription of antioxidants and we wonder, whether the doctor is looking at antioxidant or selenium or a micronutrient prescription for nutritional deficiency, or is it for pain management? Can you briefly talk about papers which have shown antioxidant and pain management in chronic pancreatitis, just for the understanding of dietitians?
So I think what we are using predominantly is for as an add-on therapy for pain. But having said that, antioxidants for purely isolated pain management is very, very low evidence. It's not a good quality evidence at all. There are recommendations for use of antioxidants but the amount of or the dose that is required is actually, it's not commonly found, and it's not even easy to take them. It's not very palatable for them to take that much amount of antioxidants. So if I have, it's like a cocktail. If I have failed them on a good pain control, I'm giving them PERT, then I'll probably add on antioxidants if the pain is still somewhere there. I'm not really adding it for nutritional value at present. That's as a doctor, what I'm saying is I'm not looking at the nutritional value of it. What I'm trying to look at is if my patient's pain is not adequately controlled. So probably it will give me another 5%, but not more than that. And as you talked of data, it's not recommended by any of the major guidelines, whether it's ASPEN or ACG or anything, but it's a routine practice to give them. I think you will have an additional 5% extra benefit over and above. It's a more of a practical issue, but not a very recommended one. Guidelines
Right. Right. Okay. Okay. So on this note, I think I should wrap up. We have Dr. Radha. Dr. Radha is the chief dietitian and also president-elect of ISPEN, ISPEN Group National Board. So Dr. Radha, I think, wants to add on a few points because she is working at AIG and she sees a whole lot of pancreatitis patients. So Dr. Radha ma'am, are you there? Yes. Yes.
Thank you so much. Thank you, Esther. And sorry that I joined late because I had another meeting going on in the hospital.
Right.
So yeah, I did listen to all the panelists while they were talking halfway. See, what we do is, of course, the guidelines do not say, but then for pancreatitis, the guidelines does say that we have a lot of malabsorption happening there all market. You need to give a hydrolyzed protein to them. That's part of the guideline. So that's one point that we all make it for sure that we hydrolyzed fat, a product which contains more amount of MCT so that is less passing on in as steatoria. They are on PERT or they put on the enzymes, but then you have to give a hydrolyzed protein to them. Type 3C is a product where if you give a polymeric formula, there's always this fluctuation. They have very low sugars or very high sugars. So this gets corrected when you give a balanced product. So that's one more thing. And after coming to all of them have trace element deficiencies. So that is an essential part in the correction of malnutrition in these patients, that we give selenium and zinc as a very important component of their trace elements. And of course, doing body composition, but how often do they come? They come once in 3 months to us. So we need to give them a treatment which will suffice their treatment for 3 months. Right. So that's something that we have to see. Body composition is something that we know they're going down. We know that they're going to be, we know that muscle loss is there just by looking at them.
Right.
So I'll just make a quick point on just a very brief one. So understand that these patients are chronic patients. They are somebody who would require support for the rest of their life. Pancreatic enzyme replacement therapy and trace elements are not cheap. They are not cheap. If it's as good as 1,000 rupees going down every month. So first and foremost, it is your normal diet and your normal nutrition that should take place. That discussion should be 95% of your time. And yes, 5% we have to add on PERT, we have to add on trace elements. But as cheap as they are not expensive. So some of the patients, most of them will stop therapy in between. In fact, the good data say that after 6 months, most of them stop using PERT as well as antioxidants. So even if you give them for 3 months or 6 months, they don't take it if it's expensive. So ultimately, it's our diet. How do we manage it?
Right. Okay. Thank you. We will have a short time to take some questions, maybe 5 minutes, because there are some questions that have come in the panel. Vandita, can you come on?
Yes, ma'am.
And yeah, so if you have any other questions other than what I can see, or shall I just take it up?
Yeah, you can take it, ma'am.
Yeah, okay. So I think we started off with Dr. Jayanti asking a couple of questions. How early is early? I think that Dr. Ganshyam did answer that. There have been questions on glutamine and immunomodulating supplements. Dr. Zubin and Dr. Ganshyam, would you like to add on to that? When do you initiate glutamine or immunomodulating supplements? Edwina?
My short
Yes.
answer is I do not.
You do not. Okay.
Yeah,
Dr.
the
Ganshyam?
only indication for glutamine would be if the patient is on parenteral nutrition. Otherwise,
Okay.
no. That is similar to any other patient where if the patient is on complete parenteral nutrition, it's a level 1A recommendation to kind of add glutamine, right?
Okay.
Not something which is very, very exclusive to pancreatitis, but then again, any other patient who's on complete parenteral nutrition, you would want to give glutamine.
So if you want to read in detail, there was a good Redoxo trial in NEJM 2013, which was the negative
Yes.
trial for glutamine.
Yeah.
Yes,
The problem with Dr. Zubin, the problem with that trial was, right, Dr. Helen's group had published a trial. They had used phenomenally high doses of, the total
Yes.
proteins and the
Yes.
glutamine. In fact, they used in those subset of patients where it is contraindicated, right?
Yeah.
Right.
Patients, a good number of patients were having liver dysfunction, renal failure. So,
Renal
right,
failures.
as I said, not routinely, but if the patient is on complete parenteral nutrition, yes.
Yes. There was one question where I think this was for Dr. Ganshyam. If the abdominal girth is not measured routinely, what can be done?
The intra-abdominal pressures is not a very complicated technique. It's very simple, right? Majority of these patients do have a Foley's catheter in situ. Okay. All you need to do is, if you just go to the internet and then just type how to measure the intra-abdominal pressures, you have got beautiful descriptions. It's a very simple technique. You just need an extra IV cannula and you need to instill about 25 ml of fluid, block the Foley's. It is it's very simple way of measuring it. The other thing that you can do is, though it's not directly a measurement of the intra-abdominal pressures, you can use your ultrasound to see what's happening with the peristalsis. You can use your abdomen to see what's happening. If you're good enough, then some people can also pick up the vasculature. In fact, whether there is gut ischemia that's coming up or not. If your peristaltic movements are kind of decrease, all these point to the fact that your gut is failing. So measuring intra-abdominal pressures is not very challenging. It's very simple. My request to all of you is, please just go to the internet and just Google out the technique. It's very difficult to explain it, but once you know it, you don't need high-end equipment. You need a Foley's catheter, you need a stand, and you need a pressure transducer, which majority of the ICUs have for measuring either the central venous pressure or the arterial pressure, right? So it's a very simple technique.
Okay. Okay. So Dr. Ganshyam, stay on. And Edwina, there's one question. Do we not follow hypocaloric feeding, as most of the patients with SAP will be in ICU?
You would follow it, but that's only in initial stages.
In acute phase, yes.
First, say 48, 72 hours, not later than 3 to 5 days.
Yes.
Right. Yeah.
It's
You
only
want to
in
add on,
initial
Edwina?
stages. Yeah.
Yes.
In acute phase, hypocaloric feed is definitely what we follow as per the critical care guidelines. And later we will progress in the transition phase, what we talked about. Probably they get into hyper metabolic phase. Their resting energy expenditure is high. And that is where we provide around 25 kilocalories per kg. And according to the recommendation also, at least due to the inflammatory state, protein recommendation goes beyond 1.2 gram per kg body weight later on. Yes, that's right.
Okay, so Edwina, last question to you. Role of MCT to meet energy requirements. And if Dr. Radha is also there. Role of use of MCT to meet energy requirements in patients with chronic pancreatitis.
Of course, for high energy requirement and high protein requirement, we can include ONS for a short duration and in CP, chronic pancreatitis basically, and MCT based most of these formulas, if we have to pick and choose with MCT, That would help in case of malabsorption. We will have to check in case if there is any steatorrhea signs. So depending on that, probably we can take a decision on using MCT-based formulas.
Okay, thank you. Thank you, Edwina. So before we close, one comment from each of the panelists. We start off with you, Dr. Zubin. One comment for a nutritionist.
Feed early, feed full, don't stop your feedings.
Dr. Ganshyam.
See, acute pancreatitis is it's a disease of many phases, many complications. You need a team approach, right? Many a times individual decision making may be a little difficult, tough, and complex. Get the team involved. Working as a team always helps when you're dealing with such complex conditions.
Thank you. Dr. Monish?
Yeah, I would stick with what Dr. Zubin said. Feed early, as much as possible, feed by mouth, followed by enteric feeds.
Dr. Radha and Dr. Edwina?
Yeah, feeding is essential, and of course, multidisciplinary, as Dr. Ganshyam said. Yes, follow a protocol. That's more essential than anything else. Following a protocol is more important than doing whatever we want.
Edwina, you have the last word.
I would say monitoring and intervening accordingly would be also necessary.
Yes. Thank you. Thank you, panelists. Thank you, everyone, for the time given. And over to you, Vandita, to wrap up and close. Thank you so much.
Thank you for an excellent session. I think everyone has benefited with, like, be it with the dietitians or doctors. It was an excellent session covering all aspects. So we thank you all the panelists for joining the session today and all the participants. And thank you, ISPEN, for collaborating again on this webinar. Thank you, everyone.
Thank you, everyone.
Thank you.